Hi, everyone. Welcome back. Today, we're joined again by Dr. Eddie Stenehjem to give our weekly COVID-19 update for the community. Dr. Stenehjem, as always, thank you so much for joining us. We appreciate it.
You got it.
So I'm going to start with case counts like we normally do and just kind of go over what's been happening in the last week since we spoke. The total case counts in the state of Utah are 243,915. Our daily case counts yesterday were 3,203, which brings our 7% or 7-day rolling average to 22.2%. Our total deaths in the state of Utah are 1,126, with 30 deaths reported yesterday. Our hospitalizations are at a total of 9,791, with yesterday's hospitalizations reported at 556. The state's website has also added vaccinations into their data reporting, so I'm going to report on that from now on too. The total is 407 as of yesterday. I want to talk about how our hospitals are doing first. The state's reporting we're at 101.1% referral hospital capacity. What does that mean? How can a hospital be over 100% capacity on something?
Yeah, so I think this is a great example of what are kind of leading and lagging measures. So cases come out first, then lead to floor hospitalizations, which then increases ICUs, which then increase deaths. And so right now, what we're seeing is we continue to have very high rates of ICU capacity across our referral centers and ICUs just in general, even though our case counts are decreasing. We'll start to see that ICU number start coming down, probably in the days to weeks to come, ideally. But keep in mind, when a patient gets into the ICU with COVID-19, that typically isn't a short hospitalization. That many times, average length of stay is between kind of 10 and 11 days. And so it takes a while for those patients to either get well enough where they can move out of the ICU or unfortunately pass away. And that obviously opens up a bed in the ICU. And so the fact that our ICUs are still just teeming with COVID-19 patients is just an indication of our really high case counts from a couple of weeks ago. So that's one. Keep in mind too that there's a difference between available beds and staffed beds. And so we may have beds in the ICU, but they may not be necessarily fully staffed with our caregivers. And the challenge with this metric too is that we continue opening up new ICU beds in places that necessarily hadn't been available. So at Intermountain Medical Center, we opened up ICU beds in one of the cardiology floors, which is a general cardiology floor. But those are now ICU beds, and those then get added to the denominator. And so you see a number of ways that you potentially could get above that percent capacity. And this is a Utah Department of Health metric. It's not an Intermountain metric, so I can't speak to the details of how they calculate their percent capacity. But those are just two examples of how you could get over that capacity by, not necessarily counting staff beds, counting all beds. And so you kind of go over the amount of staff beds that you have people in, or the amount and the denominator can be impacted as well.
We also talked about last week how we didn't really see this Thanksgiving surge necessarily, but what we are seeing now is an increase in deaths. I think we've had a couple of days over 20 deaths last reported this week. What does that mean? Are we not testing enough? Are we not catching enough initially? Or how does that really work? I know you've talked about the laggingness of this before, but should we be seeing this much of an increase in our daily death count?
Right. So, we had this really very significant increase in cases. The governor put in some mandates that went into effect about 2 weeks before Thanksgiving on Monday. Right before Thanksgiving, we started seeing the case counts coming down. We got through the holiday weekend with really low testing volumes, but high test positivity. We then saw cases come back up for a short while, and now you've seen a relatively consistent decrease in cases over the past 10 days or so. And so we are seeing a decrease in cases, but we can't forget the fact that we had a huge spike the 2 weeks before Thanksgiving. And so those are, an increase in cases. So case detections at all of our drive up sites, Utah Department of Health sites, University of Utah sites, Test Utah sites, those were where we're identifying. Those cases then go on and get hospitalized 10 to 14 days later after that case detection. Then typically they're hospitalized, they either get better or they get worse. And a lot of those people who get worse, they go to the ICU. In the ICU, they may be in the ICU for many days and either get better or get worse. And so the deaths that we're seeing right now are due to the big increase in cases we saw before Thanksgiving. And so, we absolutely predicted this. And, we talked about this, earlier this week in a number of broadcasts, the fact that we anticipate to see more deaths. We anticipate to see that death count rise because that death count right now is really from the big increase in cases that we saw before Thanksgiving. And so, yes, we definitely anticipated this. And this is one of these lagging measures. And we hope then as cases have come down since then, what we're going to start to see now is cases eventually starting to come down, which would reflect our current trajectory of cases. So it's complicated in the fact that deaths are so delayed from when diagnoses are made.
What is the age range if we're seeing one that positive case counts are coming from? Is it still that younger 15 to 24 age range? Has that changed a little bit, or has it kind of stayed the same?
Yeah, so that's something we are, clearly watching closely because that impacts kind of some of those public health measures that we really are talking about. What we've seen and what we continue to see is that the cases are going down in all age groups. Okay, and so in that 15 to 24-year-old, we saw a really big spike, especially post-Halloween, that then led to this big spike in hospitalizations. But now when you look at the individual age groups, what you're starting to see is a trend down for all of them. Okay, and so that really isn't indicative of good, sound public health measures being adopted by the community. So it's not just an intervention in the high schoolers and college age, but it's really seeing that reduction coming down, which is likely leading to decreased spread within families. But you're also seeing a reduction in all age groups kind of happening in parallel. And so really what we think that is from is just one, people heeding public health measures, which is just awesome. People in Utah are saying, yeah, okay, I get this. And there's so many people across the state that are taking these measures seriously and actually doing them.
I want to switch gears to the vaccine. So as you mentioned, we've had a couple press conferences around that, and people have been getting vaccinated. We did our first set on Tuesday at LDS Hospital, and you got vaccinated this week. How was your experience getting vaccinated? Are you feeling any sort of side effects from that? And will you tell us when that happened too?
Yeah, so I got vaccinated yesterday, which is just so amazing. I was in that first tier of people because I'm actively caring for patients in the hospital, both COVID and non-COVID alike. And so I fell in that kind of first tier of healthcare workers that would get vaccinated. I'm feeling actually pretty well. And so I have some muscle soreness in where I got vaccinated in my deltoid. I would say that it probably doesn't feel any different than, a flu shot or a tetanus shot so far. Last night I felt, a little tired, maybe some mild kind of, muscle tightness. But I've got a 2-year-old and an 8-month-old, and it's a global pandemic. So I'm just tired all the time. So I'm not sure how much of that is attributable to the vaccine or just attributable to the fact that I'm on the consult service and I'm just tired. Most side effects per the study occurs on the second day. So that would be today for me. So I was actually anticipating waking up feeling kind of off, a little punky. But so far I feel totally fine. I went out, I shoveled this morning. I still have a little soreness in my arm, but I feel pretty normal, compared to any other day. So we'll see. It'd be interesting to see how I feel throughout the day. I would say that when you look at the studies, most people, if they're going to have symptoms, the symptoms are worse after the second shot than not as much in the first shot. So far, so good. A number of my ID colleagues also got vaccinated either Tuesday, Wednesday, or yesterday and Thursday. And so we've been talking around the office. One person had some kind of mild muscle aches. Nobody's had any kind of high fever by any means. We've had a couple of people feel absolutely totally normal. So far in our experience within the high infectious disease division, there hasn't been any really side effects at all, outside of this things you'd expect from a flu shot.
That was going to kind of be my question. Do we expect normal side effects from this vaccine like we get them from the flu shot? I know I got my flu shot in October, and for some reason, this one did leave my arm sore for a little bit longer than normal. But is that kind of what you expect with vaccine, is that you have these types of normal reactions because your body's adjusting to it? Or what are the reasons for like the muscle soreness that you have anyways?
Yeah, so when you look at this vaccine compared to other vaccines, this is more what we call reactogenic than traditional like influenza vaccines. And so what I mean by that is when you look at the study population as a whole, more people will have kind of systemic side effects. And so fevers, chills, fatigue, muscle aches called myalgias are more common in this vaccine than in the influenza vaccine. In terms of local side effects, meaning local where you got the injection, that kind of local side effects is pretty similar to a number of other vaccines. Shingrix is the one that comes to mind. That's the herpes zoster vaccine that's been now across the market in a number of years now. That has a lot of local side effects. This one's very similar to that, where you've got muscle pain. And so it falls into kind of the realm of normal of a reactogenic vaccine. Why people have fevers, chills, fatigue, headache that's the sign of your immune system working. That's the sign of your immune system getting revved up, responding to a new protein that's being displayed on some of your cells and developing an immune reaction, which is generating antibodies and memory cells and T cells. And so then the next time you see that protein on a live virus, it can respond to it and essentially prevent you from becoming ill. And so that's really just a sign of your body's response and your immune response kind of kicking in. And so, it's actually a good sign that we're seeing that. That means that we're developing an immune response to this protein on the virus.
We also know there's another vaccine that is going through the same processes that Pfizer went through, the Moderna one. Can you talk about the differences between the two vaccines, if there are any?
Yeah. So Moderna vaccine underwent review by the independent advisory board to the FDA of VRBPAC yesterday. VRBPAC reviewed all the data, and again, that Moderna data, just like the Pfizer data, is publicly available. FDA makes that publicly available. So they reviewed all that data and voted on it yesterday. They voted 20-0 to approve that vaccine to the FDA. The FDA, most likely, I'd imagine, if we kind of look at what they did last week with the Pfizer vaccine, will make a decision on emergency use authorization, likely, I would imagine, tonight, tonight, maybe early tomorrow, something like that, to approve the Moderna vaccine for an EUA, just like Pfizer vaccine has an EUA. The CDC and the ACIP, the Advisory Council of Immunization Practices, will meet this weekend and give recommendations, just like they did with the Pfizer vaccine. And so we anticipate that the Moderna vaccine will get EUA approved, CDC will approve recommendations, and that it'll likely be shipping on Monday, I'd imagine. Just same kind of timeline as like the Pfizer. So Moderna and Pfizer are both what we call messenger RNA vaccines, or mRNA vaccines. They are delivering a segment of RNA for the spike protein into our cells. Our cells take that up, essentially read it, make the protein that is encoded on that RNA. That protein is then expressed in some of our cells, and our body then makes an immune response to that bit of protein that is expressed on our cells, which then generates an immune response. So the RNA of the messenger, or pardon me, of Moderna and Pfizer are essentially identical. They both are the RNA for the spike protein. So it's the entire gene of the spike protein that this mRNA encodes for. So that part is essentially the same. The difference is in the delivery, and there's these nanoparticles that allows this RNA to get into your cell, not into the nucleus where your DNA is, but into the cell to be then read. And we don't know a ton. That's very proprietary kind of information in terms of what they use, but that's the difference, and that's why the Pfizer vaccine has to be kept at ultra cold temperatures, where the Moderna doesn't. It likely has everything to do with the vehicle in which that RNA comes in. And again, we don't know a ton about that because that's very specific to the manufacturer.
And both vaccines require 2 doses, correct?
That's right. So the Pfizer vaccine is 21 days apart, 3 weeks apart, and the Moderna vaccine is 28 days apart. That's just where their phase 1 studies kind of played out, and that's just the way that they are operating the trials. And so, for me, I had my vaccine on Thursday, so just after the new year will be 3 weeks for me, and I'll go ahead and get my second dose of the vaccine. Then Moderna would be a full 28 days after the first dose. And so it's really important for everybody, as this rolls out, to make sure that you get that second dose. We're not certain what the longevity of an immune response is after 1 dose. The studies were set up with 2 doses. And so we have to go off of what that study showed. And the study showed 2 doses result in 95% efficacy. So we really have to make sure that we all get that second dose of the vaccine.
Someone just asked us a question around how many people in Intermountain system has been vaccinated, which I read the number earlier, but in the state reported yesterday, and I don't know what the timeline is on the state's reporting, if it's the same 24-hour period, but we were at 407, and Intermountain has over 40,000 employees. So there's still a lot more people to get vaccinated. But as far as maybe your team or the people that you work with, has everyone been vaccinated in kind of that bubble? And when do you think we could expect to finish vaccinating? Let's start, say, with the first round of people that qualify.
So you're right. Intermountain Healthcare has 40,000 employees, 40,000 caregivers. And so we have set up a tiered approach within Intermountain. We can't just say, hey, all 40,000 of you come get vaccinated. We just, that's not feasible. And so the first tier of kind of the caregivers that are getting vaccinated are the ones that are at the highest risk for encountering patients with COVID in kind of severe disease. And so that's people that work in the hospital, ICU, staff, whether it be physicians, nurses, respiratory therapists, the folks that work on the floors, the hospitalists, the nurses, those types of things, those, physical therapists that work in COVID units, then consultants that are interacting with COVID positive patients and other patients across the facility. Those are all the people in our first wave. And so we really want to focus on getting them vaccinated to keep them safe, because we need them to be able to keep operating at such high volumes. And so those people have started getting vaccinated just on Tuesday. And so we'll be running through, obviously, all of those people. Once we've offered the vaccine to them, then we'll go on to kind of the next tier. The next tier, people that may work in the hospital, but aren't as at high of a risk. They're at potentially moderate risk. Then we'll start vaccinating them. And then tier 3, which is essentially all other caregivers. So urgent care docs, ED docs, they're all in that first tier. And so we're in the process of getting all of them vaccinated. I don't have the numbers on that, but they sent out the vaccination requests, and I can tell you people got scheduled and are getting vaccinated. I got vaccinated yesterday at Intermountain Medical Center, and it was a pretty unique experience in terms of it was just a celebratory atmosphere. The caregivers that were there giving the vaccine, getting the vaccine, it felt like a celebration. People were so excited to get this vaccine to offer another layer of protection to us in addition to our PPE. And it was just such an incredible moment in science, and the fact that we got the genetic sequence of this virus in January, and here we are in December getting vaccinated with a vaccine that is 95% efficacious. It is mind blowing. We would have never been in this position to be able to do this if it wasn't for all the research that's gone into vaccinology in the past 10 years. And so it was just such a heartwarming experience just to see this in action and see that it's here. It's finally here. This is our way out. And so it's really pretty unique. In terms of kind of the timeline of when do we start seeing other people get vaccinated? So keep in mind, the recommendations for this first phase 1A, is healthcare workers and patients and workers in acute care facilities or long-term care facilities, nursing homes, skilled nursing facilities, et cetera. That's the first wave. The second phase, we'll call phase 1B, will be getting guidance from the CDC and ACIP on what that next phase will look like. It will most likely include essential workers and people at high risk of having a poor outcome if infected. So this is a really big group of people. Essential workers will include teachers and grocery store workers and EMS and first responders. All those people are essential workers. And then people that are at high risk are people that have underlying medical comorbidities or above the age of 65. Once we get that kind of advice from CDC and ACIP, it's up to the state health department and the Utah legislature to say, do we go by that or do we make any modifications? And you've already seen Herbert say, we're going to get our teachers vaccinated first. They fall into that essential workers. So we hope to get that recommendation soon from the CDC. And then after the new year, really start into that phase 1B in terms of vaccinating those essential workers, teachers, and high-risk patients. It'll also be really dependent on how much vaccine we keep receiving from both Pfizer and how much we start receiving from Moderna. And so the timeline on that is really going to be dependent on, vaccine supply, how much we're getting from these companies. But I suspect probably late January that we're going to start in on those people. But again, that's subject to change based on availability.
That was one of the questions we just received around if we are receiving enough doses that we thought we were going to initially received. And I just want to point out too, I work for Intermountain and I have not gotten the vaccine. So we definitely have not gotten through everyone, and I'll probably be one of the last people. I don't have any comorbidities. I'm younger and I don't work on the front line. So I think that's important to remember is I work in healthcare, but I'm nowhere near the level that you guys are. So when people look at those tiers, they should look at kind of, okay, what's my role within this company and what do I do? I think that's important.
Right. Yes. You're right. Not all 40,000 caregivers are at risk. I mean, so we have people working in central offices and in billing and in, a lot of these places that don't have a heightened risk of COVID-19 based just because the fact they work in healthcare. And so, we're taking a very tiered approach in terms of who in healthcare is receiving this vaccine to ensure that we're not, overdoing it on our 40,000 caregivers when we could be giving that vaccine to people that need it more than us. And so it's a very thoughtful approach. And to the question is, we'd always love to receive more vaccine, right? But this is based on the Operation Warp Speed in terms of how much we're receiving. And, that's coming through the Utah Department of Health.
And have we received the amount that if you know the answer to this, have we received the amount of vaccines that we were anticipating initially with this kind of round one of vaccines?
Yeah, and I honestly don't know the answer to that. I know that we received initially less than we had anticipated, but then we were going to get more shipment quickly. So those kind of decisions and monitoring of that is happening at the Utah Department of Health and not necessarily with our team.
Another person asked a question around the importance of seeing public figures. Vice President Pence got vaccinated on live TV. You've been vaccinated. A lot of infectious disease physicians have kind of recorded themselves being vaccinated. What do you feel like the effect is on the public watching these important figures get vaccinated? And do you feel like it'll ultimately increase the percentage of people who actually get vaccinated?
I sure hope so. I think it's important. I think seeing our leaders get vaccinated gives people faith in terms of the science and in terms of the safety of this vaccine. This pandemic has been highly politicized, and so it's great to see people on both sides of the aisle and getting vaccinated in a public display as well. from our standpoint, the reason that we wanted to be pretty vocal about us getting vaccinated is because we're the people that know the most about the trials and the science behind this vaccine. We've looked under the hood. We've poured over the data, both Pfizer and Moderna. The hundreds of pages of documents that they submitted to the FDA. We've reviewed those. We reviewed the side effect profile. We reviewed the effectiveness of this vaccine, and we deem this a very safe and useful vaccine for our communities. And as a way to demonstrate that to people, we wanted to be very vocal and visual about us getting the vaccine. I certainly don't want to take an unsafe vaccine. And so if I thought it was unsafe, I wouldn't take it. This is a safe, it's an effective vaccine. And I'm hoping that this is one way for us to demonstrate, our faith in this and our faith in science and the fact that this is the way forward for us. And I hope that changes. And I think there has been, I can't say it's due to what we've done, but, we've seen the rate of vaccine hesitancy as it relates to the COVID-19 vaccine go down. And so now a recent report came out that showed 70% of the US population would be willing to get this vaccine. Just a couple months ago, that was 50%. So I think we're starting to see people understand that, yes, this is a safe, effective vaccine. This is good for our communities. It's good for me personally. And I hope to see that number continue to rise.
And as far as the general public goes, I know there's kind of this fluid timeline of when someone like myself or anyone else could get the vaccine. We're hearing dates from March to July. Do you know, or can you indicate when that will kind of firm up in terms of an actual timeline of when we could expect more people to be able to get vaccinated?
Yeah, the Operation Warp Speed director has been very optimistic in terms of when anybody, general population, could get a vaccine. And he's come out and said between March and June. Then you have some other leaders, whether it be former FDA commissioners and CDC leaders, say it's probably going to be June or July. And so I think we're seeing kind of a lot of variation, and we don't really know. One of the big reasons that there's a ton of kind of ambiguity in there is that the more vaccines we get EUA approved, and keep in mind all those vaccines are producing vaccines even before EUA approval, the more vaccines we get approved, the more vaccines are available to our public. And so Pfizer and Moderna are the first two, but keep in mind the Johnson & Johnson vaccine and the Oxford vaccine with AstraZeneca are nearing completion of their initial phase one or the initial part of their phase 3 studies. And so it could also be that in January, we get 2 other vaccines approved under an FDA EUA, which would be J&J and AstraZeneca. And then that would allow even more vaccines to be brought into our communities. And so it's hard to predict those types of things. But I think, looking at the number of people talking about this that have some kind of insight into it, I think it looks like April to July is the time period where we'd see, if anybody wants a vaccine, they can get one. I think that's really kind of a realistic time frame.
I know we talked about this a little bit last week, but it's something that we keep seeing around pregnant women or those who are breastfeeding and the safety of this vaccine. What is your advice for those women who fall into the maybe initial categories of getting this vaccine? What should they be doing? What risks and associations should they be talking about?
Right. It's so the trial that have been done for Pfizer and Moderna, they excluded pregnant women. And this is incredibly common. Pregnant women are special populations, and so they many times aren't in that first wave of vaccinations in those trials. Pfizer did have 24 patients that were pregnant or became pregnant after the first dose, just by chance. The people didn't know they were pregnant when they got signed up, and then they subsequently found out that they were pregnant. And very small numbers, and half of those got the placebo and half got the active. So now you're talking about 12 people, and so it's very small numbers, but it appeared safe in that small group. The American College of Obstetrics and Gynecology came out and said it's okay. Pregnant women can get this vaccine, and we support that. And they shouldn't be excluded from getting the vaccine. If a pregnant woman wants to get this vaccine, they should get the vaccine. It really comes down to assessing your risk of getting COVID-19 and the benefit of having a vaccine. This is not a live virus. Okay, so it's not like there's any component of live virus. You cannot get infected with COVID-19 from this injection. And so scientifically, this should be a very safe vaccine to give in pregnancy. We give vaccines in pregnancies other times. Influenza, great example. We give that in pregnancy. This will likely fall into it eventually. The problem is we just don't have any data. So ACOG recommends it and says, talk to your obstetric, your OB physician in terms of if this is right for you, if you have any questions. And I think ultimately you're going to have to weigh the risk versus benefits. And so if you had a frontline caregiver working in a COVID unit who is pregnant, that's a person that is at high risk because we know that pregnancy is a risk factor for severe disease in COVID-19. That's a person who'd be like, potentially say, listen, the risk of me getting COVID-19 is higher than the risk of me getting this vaccine and potentially having a very rare complication. And so it really comes down to risk benefit. ACOG says, yes, go for it. We think it's safe. Talk to your doctor about it. Ultimately, what we're going to say, and we've had these discussions with the head of women's medicine, women's health within Intermountain, is to say, this is going to be a decision between you and your provider. But within Intermountain, we're not going to have pregnancy be a contraindication from getting that vaccine.
I think that's important. The talking to your provider, like you mentioned, kind of figuring out the risks of if you contracted COVID-19, what are my risks of the side effects or long-term effects of COVID versus the vaccine. So I think that's important. I want to talk about the clinical trials in children as well. I know that they just started them for under the age of 16. I think it's 12 to 16, if I'm remembering correctly. Will you talk to us a little bit about when we can expect to see any sort of data from that clinical trial?
Yeah, it's going to be a little bit. The Pfizer vaccine included the 16 and 17-year-olds in their study, and there just wasn't that many 16 and 17-year-olds in the Pfizer trial, and the endpoints were very, very few in that 16, 17-year-old group. Moderna only included 18 and up, so we have no pediatric patients at all in the Moderna group. And like you said, they've opened up the trial now to the 12 to 15-year-olds. It's all going to be a function of how many people they enroll and what this pandemic does in terms of spread. And so it very well could be a little bit, because they're not going to have 40,000 12 to 15-year-olds signed up in this vaccine trial. So it's going to take longer to get to the endpoints. And keep in mind that the younger population are less likely to have symptomatic disease. Symptomatic disease was the primary endpoint in both the Pfizer and Moderna trial. And so now you've got fewer people in that age group. You are hopefully at a time where case counts are decreasing and they're less likely to get symptomatic disease. It's going to take longer to get results from those, from that subgroup of patients that are getting vaccinated.
Another question around that, the guidelines for quarantine for students were just adjusted for 2021. It was now stated that if you were exposed to 19 and you were both wearing masks, a quarantine is no longer necessary. What are your thoughts on that? Do you feel like this is going to be an effective way to mitigate the virus?
Yeah, I mean, the whole point is we want our kids to be in school as much as possible. So that's one. And two, and again, I wasn't part of any of those discussions or decisions, so I'm just, kind of reflecting on it. Two is we also know that masks work. The science behind masks is clear. They are a very effective method of preventing transmission, especially when both people are wearing masks and wearing them well. And so in what I would call a low risk exposure like that, mask on mask, that is a low risk exposure. And that's because we know the effectiveness of masks. And we also know that our kids can wear masks. We initially thought like, oh, kids are never gonna be able to do this. We didn't give them enough credit. I mean, kids are great at wearing masks, especially, in a classroom in a monitored environment. And so I think that's, very reasonable. And talking with some of our colleagues who have looked at a lot of this data, the rate of positivity amongst those that had a low risk exposure during quarantine is really low, and pretty similar to the general population. And so I think what they're doing is they're using data to inform their decisions to ensure kids can stay in school. And that's got a huge benefit to the child and to the parents. And so, I commend them from actually making data-driven decisions on how they're addressing the quarantine.
Back to the vaccine really quick. I want to talk about that 70% threshold that we've kind of heard with herd immunity. If less than 70% of the population in Utah get vaccinated, are we going to be in danger of kind of falling back into this fall surge again come fall 2021?
Yeah, so keep in mind what we want, or think about herd immunity. We try to develop herd immunity to eliminate a virus, to eliminate an infection. So for example, measles. If we are above that threshold from a measles standpoint, and if measles enters our community, there's not enough susceptible people there to propagate the spread of it, okay? And so that essentially is a way to eliminate an infection in our community. Okay, so that's what happens at that threshold of about 70 to 80%. That's what herd immunity does. It's eliminating the spread of this infection. As we vaccinate more and more people, especially more and more people in that high risk category, what that will do is it will decrease the number of hospitalizations and deaths in that group. Okay, and that is ultimately our number one priority. Our number one priority is to decrease severe illness in the population that is at the highest risk, and thus decreasing death. Okay, that is our number one priority, is to make sure that people out here in our communities are safe from this infection and don't die. And so as we increase our vaccination of those populations, that's what's going to happen. And we don't have to get to the 70% threshold. What we'll see is as we increase the vaccination in that population, our rate of hospitalizations are going to go down because that community in that population is protected from the vaccine. That isn't herd immunity, right? That's meaning that the virus is probably still going to be circulating, especially in people that don't get vaccinated. Younger people, for example, but we know that those people don't have high rates of severe illness. Okay, and so what we may see come fall, and it's hard to predict because we don't know what vaccine distribution is going to look like. But ideally, what will happen is that we may see transmission of this virus, but we're not going to be seeing as much transmission in that high risk group that ends up getting hospitalized and dies. And so I think we're going to continue to see transmission of this virus, but ideally we'd see the transmission in the younger age group that doesn't have severe illness. I do think it's very worthwhile to try to get to herd immunity, but keep in mind, herd immunity is really dependent on how long the effects of the vaccine lasts. If the vaccine only lasts a year or 2 years, that means we're going to have to repeatedly vaccinate everybody to maintain herd immunity. Because once you stop vaccinating people and that immunity goes away, then you have a susceptible population. So it's a really kind of nuanced decision in terms of what is our goal of vaccination. Our goal of vaccination right now is to prevent death and to prevent hospitalization. That isn't the same as herd immunity. Herd immunity is trying to prevent transmission altogether, which is dependent on vaccinating everybody up to that level of 70 to 80%. And it really prevents the spread of any infection in the community.
Another question we just got is around allergic reactions. We've seen a couple of reports of just a few people having allergic reactions related to the vaccine. What are your thoughts on these allergic reactions that are happening, and how is Intermountain monitoring people once they get the vaccine?
Yeah, so it's really early in this, but there was a report out of Alaska with 2 people having an allergic reaction. And those 2 people were also people that had severe allergies at baseline. Think of somebody who carries an EpiPen with them on a routine basis because they're so predisposed to severe allergies. It's super early in this. We didn't see this in any of the clinical trials, but now as we're getting this out into the public, we've seen a couple cases of this. And so CDC has made some recommendations. And so what Intermountain does is that once you're vaccinated, you go and you stay in an observation room for 15 minutes, and then you can go about your day. And so that's pretty common for vaccines, is to have an observation period to make sure there's no immediate adverse events like an allergic reaction would occur relatively immediately. And so that's just an extra measure we're taking. We haven't seen anything of any concern but we've only been vaccinated since Tuesday.
Another question for you, switching gears a little from the vaccine. Someone wants you to describe the areas of the hospital where COVID patients are being treated. What would it feel like to walk through those areas?
Yeah, so there's two main types of units that people are cared for when they have COVID-19. If they don't require super intensive monitoring or very, very high flow oxygen, they go to a general medical ward, which is kind of what you'd anticipate, a general hospital ward that people get cared for if they have pneumonia or any other kind of condition that requires hospitalization. Or if they require really high levels of oxygen, or if they require being on a ventilator, they go to the intensive care unit where they can get those specialty treatments. It's actually, if I were to take somebody and take you into a general medical COVID unit, what you'd be shocked by is how quiet it is. Okay, so these are units where it's totally full with COVID patients. So one of our units has 34 beds. You go onto that unit and it's a little eerie because it's so quiet. And you're like, well, that's weird. But it's because these patients don't have visitors and all of their doors are closed. And so no visitors, all closed doors. It's a pretty quiet place because there aren't ventilators, they aren't all those invasive machines beeping and nurses running around. And so what you'll see is a lot of healthcare workers going in and out of rooms, caring for patients, physical therapists, occupational therapists, et cetera, making sure that people are staying as strong as they can, but it's relatively quiet because there's no visitors, which is incredibly isolating for our patients, and all the doors are closed. If you go into an ICU, intensive care unit, this is a much more intensive environment where in the unit you walk around, it's single bed units, there's glass doors and windows so you can see in, see out from a nursing standpoint. Many of them, almost half of them are on ventilators. So they're hooked up to a breathing machine, which is next to their bed. On the other side of the bed, there's IV poles with IV normal saline to keep hydration, medications like remdesivir or steroids, or potentially medications to support their blood pressure. And you'll see a lot more flurry of activity because these are really intense, very sick people that need higher level of care. And so that's kind of the feel of it. In the ICU, most people will be in what are called PAPRs, essentially a big hood that they wear to prevent any kind of airborne transmission. And so it's loud. You've got all these fans going that are essentially making the whole unit negative pressure, meaning all that air gets sucked out and into the environment and not pushed back into the healthcare workers. That's loud. You'll hear people talking loudly because you have to talk over these fans. And so it's a very unique environment, and one that's pretty tragic because what you see is patients suffering on ventilators.
Last question for you. What are your recommendations for the holidays? Christmas is in a week from today. What do you suggest that people do when it comes to gathering with their friends and family?
Yeah, we're going to be in the same situation as we were for Thanksgiving. We are going to be in a situation where we aren't doing mass vaccination of the communities. We're going to be in a situation where we have very high rates of ICU occupancy. And so we are still in a position where we have very high community transmission rates. We had 3,000 cases reported yesterday. So we are nowhere near a place where we have low level community transmission. We are still very high rates of community transmission with a lot of susceptible community members. And so our recommendation is to keep it within your family. Celebrate Christmas with the people that live in your home, and don't be bringing in friends and families from out of town, people that are high risk. It's really important for us to, really stay safe through this holiday. And once we, if we can get through this holiday, like we did with Thanksgiving without a huge spike, if we can do that and we can maintain that level over the next couple months, January, February, then we're going to really start ramping up vaccination. And, then we really are going to have a light at the end of the tunnel, where we actually know how long that tunnel is, to be able to get back to some level of normalcy. And so I think our biggest hurdle right now, from now until we are able to get back to some level of kind of normal lifestyle, is the Christmas and New Year's holiday. That's going to be our biggest hurdle. And if we can get over that, then I'm not going to say it's smooth sailing. It's going to be, a lot easier for us to get to a point where we're going to be able to get back to some level of socialization that we can do safely.
That's really good advice. And like there's so many ways to virtually connect with people now too. We've been doing this for almost a year, which seems crazy. So just think of creative ways to hang out with your family this coming season in a couple of weeks. So Dr. Stenehjem, thank you so much for joining us again. We really appreciate it. And if you have any questions around COVID-19 or would like to see if you qualify for a test, you can go to intermountain.com/COVID testing. There's just a few short questions you'll answer. And then if you qualify, you'll be given some appointment arrival times to select from. I also wanted to let people know that if you're in the Tooele area, our Tooele Instacare is open this Sunday for COVID testing. You still need to qualify, but they added a day to their slot for this week. If you have any questions around COVID-19, there's also information on that website where you can get some further information. We also still have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. Dr. Stenehjem, thank you again, and we'll talk to you next week.